Hi, everybody. Welcome back to another episode of Hybrid Healing Hour. Today, we're going to be discussing food allergies with a very, very knowledgeable allergist, Dr. Shenaz Fatteh. Hello.
Hello.
Welcome.
Thank you for having me.
Yes, I'm super excited to have you on our show. After the few times I've met you and I hear you speak, I am just blown away with everything you have to say. So I'm so glad to have you on. Can you go ahead and just first tell our audience a little bit about yourself and how you got to where you are today?
Oh, thank you. And thank you both to you and Brian for having me today. So I'm a board certified allergist immunologist. My main practice is in Plantation, Florida. I did my training at Medical College of Georgia for my medical degree, and then went to University of Miami local here at Jackson Memorial Hospital, did my internal medicine training, and then went up to New York Hospital, Cornell in New York Hospital to do my fellowship in asthma, allergy, and immunology. Actually, I came back to South Florida because of family, and food allergy was not my strong point. My strong point coming through my training point was actually very much immunology, and asthma. And so when I came here, I have two children who were both born with peanut allergy. So as an allergist immunologist with my own children having now a food allergy, I had a keen sense of learning everything there is about food allergies. And over the time of the past 28 years in private practice, I have become, I think, very knowledgeable about food allergies, I hope. And I read quite a bit about this. I am the current president-elect for the Florida Asthma, Allergy, Immunology Society. And I've been president of the Indian section of the American Association of Allergist Immunologists for both the college and the Academy of Allergy for 4 years.
Wow.
So as part of different variations of leadership, attending conferences, food allergy has now become really the past 2 decades a passion of mine.
I love your drive.
Yeah.
Yes.
And we're seeing so many patients with food allergies, and I've been practicing for a long time. It almost seems to me like the numbers are increasing. Do you see that as well?
Absolutely. The numbers have just skyrocketed over the years. And I don't know if it's one, we're capturing our data better, right? Understanding. But certainly food allergy prevalence has increased. And I don't see a shortage of that decreasing over time. It's for multiple reasons. Food allergy has been definitely increasing over the last 2 decades.
So we've done several podcasts in the past talking about how we do, checking leaky gut, and we do food sensitivity testing. Can you explain what today we're talking about is slightly different than that, right?
Sure. So,
and what's your intake on that, right?
Oh, that's a very good question. So, we think about leaky gut and food functional symptoms. Patients often come with the exact same symptoms, whether it's a food allergy or some of the overlap symptoms with functional gut disease. And it can be abdominal pain, bloating, nausea, diarrhea. The key difference is that food allergic reactions come through an IgE-mediated pathway. That is a specific immunoglobulin that sits on certain cells in the body. And once the immune system has recognized that food, it processes it incorrectly, then it can cause repeat exposure, can cause serious reactions. These reactions tend to occur in minutes to hours. In about 2 hours, they are causing a release of mast cells, which are a type of cell in the body that these receptors, IgE, sits on, this molecule. And once there is binding, then it releases chemicals like histamine, leukotrienes, prostaglandins, and a host of other chemicals, which all lead to the acute allergic reaction that we're very familiar with. These are patients who start with itching. They can start with skin rashes like hives. They can develop swelling of the lip, mouth, throat, and eventually even have symptoms with bronchoconstriction, airway symptoms, shortness of breath, cough, wheeze, and blood pressure over time can drop. And that's really the key thing that we worry about in these IgE-mediated food allergic reactions, is that we can actually develop anaphylactic shock. And shock is shock, whether it's cardiovascular or, from cerebral shock. It means the blood pressure has dropped, and that's because of all the vascular leakage that's going on, and patients need to be attended to immediately. It's what we think of as a very acute, life-threatening reaction.
Mm-hmm.
Are nuts the most common of the food allergens?
So some of the food allergens that are really prevalent really are milk, egg, peanut, tree nuts, soy. So a lot of these are very common. Over the years, we've even seen an increase in sesame, some of the seed. And for example, sesame seed cross-reacts in a third of patients with tree nut and peanut allergy. So yes, and that's the difference between the acuity and the presentation versus somebody who's having, say, the leaky gut that you mentioned earlier. Those patients tend to have a slower onset. They may ingest something, and it could be a couple of days later that they start feeling symptoms. And they're more difficult to identify because there's not really key tests for that. There could be a lot of different causes, and it can lead to a lot of chronicity. And it can be very bothersome and troublesome to the patients. Currently, we think of the elimination diet being the gold standard. Well, it's hard to eliminate everything when you don't know what's causing the problem, right? So when you talk about some of the tests that might be done, tests like IgG4 testing, which just looks at a food sensitivity panel, I think can be helpful in patients who are trying to eliminate their diet. Keeping a log, keeping something can be, very helpful. But again, I think there's real limitations in that people's recall of what they ate yesterday for breakfast, much less what they ate last week. It's just not going to happen. I couldn't do it. So having a blood test that has a recall effect, such as the IgG4 test, may give you a panel that says high, medium, and low, and at least give some direction to the patients who are having functional gut disease.
Great. I love how you just explained that, because that's exactly like what I see too. And so today we're going to be discussing more along the lines of the IgE reaction, right? The immunoglobulin, the acute phase reactants.
More serious.
Yes, the more serious.
Yes.
All right. So you already mentioned how the body reacts to this food, right? The changes like the histamines and the leukotrienes, exactly. And so what else, how do you diagnose this? And do most of your patients come to you after one incidence of this, or do they say I've had several? Does it get worse after one?
So since this tends to be acute and life-threatening, very often patients have had a serious reaction where they've at least gone to their pediatrician or physician for consultation. And most doctors will recognize that repeat exposure, even minute quantities, right, can elicit a massive reaction. So it's not once the immune system is sensitized, we don't need large amounts of consumption to trigger a reaction. For example, if you think about peanut, if you have even 1/10 of a peanut exposure, if you're peanut allergic, you can elicit an anaphylactic reaction, right?
Wow.
So it doesn't take a lot. And so most of the time, patients will have a singular episode and then be referred. Certainly, we hope all our colleagues out there who listen and all patients listening know that they should have an epinephrine auto-injector with them. Because again, if it's anaphylactic shock, it's important to address that immediately and have the training and teaching to implement your epinephrine auto-injector immediately and then seek further help. Some patients, unfortunately, do wait until they have multiple reactions, thinking, well, I have this, I'm avoiding it, I'm avoiding the food. I think that's really difficult. There's a lot of accidental, and in the best case scenario, you may still have accidental exposure. South Florida, we have fish and seafood all over the place, and patients I know who are shellfish allergic to crustaceans will say, well, I can remove the shrimp from my fried rice, or I can do this and this, and then we meet them in the hospital. So that's unfortunate.
I was always told that it's the proteins that they're allergic to. So like if you're allergic to peanuts, you're less likely to be allergic to peanut oil. Is that true?
So that is true to some extent, and let's go talk about that for a second. So peanut gets broken into different fractions, and we can actually test that. So you talked about modalities, right? So the gold standard for allergy testing is skin prick testing, which is taking a purified form of an allergen and putting that on a patient's skin, and then seeing if we can see an immediate wheal and flare reaction. So the mast cell, if those Ig receptors recognize the peanut, they're going to cross-link. The mast cell is going to degranulate and release a chemical called histamine. Well, histamine will immediately cause itching of the skin and have that erythema, redness, and the wheal. So we can measure that with the appropriate controls and know that that patient's truly reacting, right? Mm-hmm. In the case of peanut and other foods, some of those foods we can also measure components. Those components are really done by lab testing. So we can also check an IgE-specific food panel by laboratory analysis. So for patients who cannot, for multiple reasons, if they have hives or if they're on certain medications that we can't stop, we can do it by laboratory analysis as well. One of the key things on lab analysis is that we have the ability to get those components, right? So that's important. Different components of the peanut allergen, like ERA H2, ERA H1 and 3, point towards more severe allergic reactions. So when you're having to talk to a patient, they don't want to have an EpiPen. They don't really want to avoid, or they think, you know what, I could have a little bit of it. I can taste it. These labs can really add to that conversation you're having with the patient. Look, you have a severe phenotype, a severe type of peanut allergy, and you really need to avoid it. Sometimes we'll have patients who will have the less reactive peanut, and that can be a guidance if we're doing testing in the office and we want to do what's called a direct oral challenge, or see if there's different protocols where we can get peanut reintroduced in the office, right? Of course, the most severe patients are the ones we want to reintroduce the most to prevent future reactions. Peanut oil is an interesting story. So I had a 3-year-old years ago who ate a peanut oil chicken and had an acute anaphylactic reaction. So I went to that restaurant, got some of their peanut oil, and actually got the chicken. And then later on, when she was well, I tested her and she was immediately reactive. So now the peanut oil back then used to contain whole components of peanut. So I think restaurants that have been predominantly using peanut oil as part of their cooking oil have changed the way the peanut is made and denatured and fractionated. So that has made it be more safe for patients to be able to consume it. For my patients who are peanut allergic, I will test them from that oil directly so that we can have clearance whether or not they can consume that food. And very often we'll do direct oral challenges. And I've done this for many of my patients that are going off to college. I think parents get concerned. And we've actually gotten the food from the restaurants that'll be on that college campus that you know your child is going to frequent with their buddies, and then actually fed them in the office in a controlled, observed, safe way so that we can know that they've consumed a certain amount and that they're safe. And I think that, is the best way to do it. What we call a direct challenge is probably the best way to ascertain whether or not patients can consume those foods.
Wow.
Can you develop a food allergy at any time in life?
I think you can. I'm a perfect example. I developed anaphylactic shock to avocado, of all things. Ate a lot of, avocado my whole life and then suddenly became sensitized. And it's interesting, in some cases you can become sensitized to different foods because you already have a known other underlying allergen. I didn't know I was latex allergic until I went to medical school. And back then, I'm going to age myself, back then we had only powdered gloves, right? So
Yeah.
Brian, you remember.
I do.
So we didn't have powder-free gloves. And so healthcare workers, about 15% of us got sensitized to latex. Well, unbeknownst to me at that time, avocado is a cross-reactive allergen to latex.
Interesting.
Yes. And so since I had known latex allergy and I'm eating avocado, it wasn't very unlikely that I might become sensitized and have anaphylaxis.
So there's actually several cross-reactivity allergies, right? I know
Yes.
I'm blanking now, but I've read something about there's a food that cross-reacts like with cockroach.
So yeah, this is one that we see in South Florida quite a bit. There is a protein in house dust mite, and if we look at dust mites for environmental allergens, cockroach and dust mites probably rank 1 and 2 in the whole world, right? And South Florida has a preponderance of both, but dust mites are a real issue for our patients, and they lead to a lot of respiratory disease from sinus congestion and symptoms, as well as to lower airways, our lungs, as well as to skin allergies in patients who suffer from chronic eczema or atopic dermatitis. And the protein that's in the house dust mite is called tropomyosin. And tropomyosin is shared in shellfish, particularly the crustaceans, and shrimp would be the most common of the crustaceans that have tropomyosin. So very often when we do testing, if you do food allergy testing and you have reactivity to shrimp or any of the crustaceans, it's really important to ask the patients if they're eating the food, right? If they've been eating it, they're doing that direct oral challenge and they haven't had anaphylaxis. I really think it's important that we document that on the forms so that they don't restrict themselves from eating that food. They can continue to eat it. Generally in a cooked form, not, steamed, but cooked shellfish then should be well tolerated. In those patients that are concerned, again, we do a direct food challenge then in the office. So that way there's no concerns.
Okay.
So I have 2 questions. You mentioned some blood tests that you can also do, right? If they're not tolerable or can't for some reason do the skin prick test. But that blood test you were explaining sounds a lot more specific than just the Quest allergen order. Like that's what I see people come in with that, and I thought those were not very specific or that useful. What's your opinion or intake on like just ordering the generic environmental exposure or food panel from Quest or
Actually,
LabCorp?
they're quite good.
Are they?
They're
Okay.
quite good. So in the early when I started my career, they weren't weighted for total IgE. And I think that's really important. The way you do an assay has to be done appropriately so that the data you get is better interpretable, right? And so the Quest assays, the ones that are LabCorp, are now weighted for the total IgE that a patient's producing. And so that helps with the clarity of accuracy of what that information that we're getting. Certainly we use where somebody has extremely high IgE levels, right? So in the serum, most of the IgE is bound to tissue on the mast cells. But let's say you have excess levels, then you may see a lot of false positive on those labs. And so that's one of the drawbacks, right? You'll suddenly see, lots of things coming in high, medium, or low on their levels. You know, if you look at it's a level 1 to 0 to 5, and a lot of patients will come in with 4s and 5s or 3s. It's like, how do I interpret this? That's where the skin prick would help discern the differences between the high IgEs, if it's true allergy or it's a false allergy. We're looking at a false positive. That happens quite a bit with children. They'll come in with their pediatric forms of their labs, and moms are concerned, what can I feed my child? So it's really important for us to do detailed food allergy history, what they're consuming. And if they're consuming all these foods and not having reactions, and we've already done the diagnostic part, we need to just thoroughly explain that to them.
So by kind of, as you say, direct challenge, right? You're by eating the foods. Is this how some people say, like, well, I used to be allergic to this, but I must have grown out of it?
So
is that different?
So that's a little different. You're talking about patients who might have had true food allergy, okay, IgE-mediated anaphylaxis to peanut, and then over time, because of strict avoidance, okay, that we may see negative testing, right? So the immune system has recall and memory, and so when we retest, we may see those patients with, very clear history of food anaphylaxis, and the testing is now coming in extremely weak or negative, and that may just be the loss over time. So those patients, when they get tested, we just reintroduce the food in the office so that it's clear that they can have this back. And there are a subset of patients that do outgrow their food allergies, right? And I think that's important to address. There are those, though, that still have retained memory. And it's remarkable, I haven't eaten this food in 20 years, and the reactions are quite clear that they're still very much sensitized.
I feel like it could go either way.
It could.
So you only know until you're in a controlled environment and you can challenge it.
That's the best
basically.
case. The best case is to do it with a healthcare provider who is knowledgeable about this. You're off of the medicines that can cause false reactions, and in a controlled way have the right amount of food consumed. So that's also important.
And in order to do, I want to actually dive right into about like the treating, right? But in order to diagnose, say you're doing the skin prick testing, or even if you do the blood work, is that you need to refrain, I'm assuming, from antihistamines and anti-leukotrienes like Xolair, Zyrtec, Allegra, all those?
Absolutely. And even eye drops.
Okay.
This is eye allergy season with all the pollen counts going up. So we'll see a lot of this. So even some of the antihistaminic eye drops, but all the antihistamines in general. And there are a few antihistamines now that are on market that are long acting, right? They have a longer half-life. And so those you may have to ask your patient to be off of for 7 days, so that they clear the body. So when you're looking at positive, negative controls, you really want robust standards so that when you're interpreting the tests that you've actually put on, your controls are worthy to be able to interpret your tests that you've placed.
Absolutely. So you do recommend for at least 7 days to avoid them. That's a good rule of thumb. Okay, great. Now, tell us about treatment. Once you diagnose somebody with high IgE levels and they're at risk for anaphylaxis, what's the recommendation?
So anybody who has a food allergy, the number one thing is avoid, avoid, avoid. Okay, it's like buying real estate, location, 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 right? Avoid, avoid, avoid. That's really trying to make sure that we, try not to have any exposure at all. That can be a bit challenging. And I think over the years, for most of us who've had children or friends or family members, and of course all my patients who have food allergy, kind of wrap my head around. Avoidance is great, but it's not always possible because of cross-contamination, utensils being
Right.
used, shared dishes, any number of things that can happen can go wrong, right? Even in the best case scenario, you go to a restaurant, you speak to the manager, you speak to your server, but still something could happen back in that kitchen. And they
Yeah.
may not mean to do it either, but not realize that frying that shrimp and then putting the chicken on that same pan, that the oils, are retained and that you could have an allergic reaction. So, one of the things that have come into the market as of last year in February was a new product called Xolair, which has been on the market for a long time for other disease states and indication, but just got the FDA approval for food allergy down to age 1. So that was also quite good because we see these foods, food anaphylactic cases when they're in infancy as well. And so Xolair was studied down to age 1. So now this is given something additional to our armamentarium or toolbox that we're giving our patients, right? As another option that could be utilized. We avoid the food that we know is causing anaphylaxis. I always have patients keep emergency devices with them in duplicate. Remember when we do epinephrine auto-injectors, and we can talk about some new EPIs if you want to afterwards,
Yeah.
but epinephrine auto-injectors should be done in pair. And that's simply because if there's a failure of the device, you have your backup, but also because severe allergic reactions that are leading to anaphylactic shock may need a second dose before you get to rescue or you get to a hospital. So you want to have that backup. You can get, improvement in symptoms and then symptoms can recur. So it's really important to have a pair at all times. So that means a pair at school, a pair with after school, after hours, school, all, and the cost of it all becomes quite expensive. That's a different discussion, but making sure patients are well covered is very important for all the different activities that they do. And then now we have the option of thinking about maybe Xolair, right?
So that's very interesting about the epinephrine, because I will tell you that most of our patients think that you get 2, so you can keep 1 at home and 1 carry with you. So I don't think anybody that I know carries both with them.
Me either.
Yeah. That I always see the patients thinking divide and conquer, right? I have one in my handbag, I have one in my car. One of the things I always talk to patients about is that, heat breaks down your EpiPen. Please don't leave it in your car trunk or you're in your dashboard, right? And I'll
Especially
have
here in
patients coming
Florida.
into my own office and I'll say, where's your EpiPen? Because I want to check the expiration date. And they're like, it's in the car. And it's like, no, I didn't hear you say that.
That's a good
Because we
test.
try to go over it with them each and every time. And then training and teaching, I do see a lot of patients get their devices appropriately when they go to urgent care or their physician's office or to the ED. There's a prescription for it, but no one showed them how to use it. And I think it's really incumbent upon us to teach and train, take the few extra minutes, teach and train. We can use our demo devices so that you can visually, see the patient use it. There's no medicine in it, but that way we can make sure we go over the location that we place the epinephrine, right? And the process. And some of the fear of using even a dummy device goes away. But that's easy. I could do this. Because one of the key things is you could have the devices, you could have anaphylaxis, and the patient may not or wait to use the medication. So we have to make sure there's no delay in treatment.
How do they use the Xolair?
So Xolair is currently looked at in patients with specific foods. So they really looked at peanuts, they looked at tree nuts, and if they have egg, milk, et cetera, those type of food allergies. So they looked at it as a single use in the clinical studies, particularly peanuts, since peanuts so predominant. And they also looked at patients who had 2 or 3 food allergies to see in patients who have multiple allergies, would it also work? On the peanut side, the patients did very well, about a 67% improvement versus placebo. The idea was that you're not going to change the behavior of patients. We're going to tell patients every time, avoid the food, right? Yep. Keep the emergency medicines, keep your medicines with you. But in case of an accidental ingestion, then this would hopefully mitigate or lessen the risk of severe anaphylaxis. So we actually look at the weight of the patient as well as their total IgE. And then based on that, and when we've done the laboratory analysis to confirm that that's the eliciting food that's causing, anaphylaxis, then we start our patients on injections. And typically that is 1 to 3 injections. The way the doses come in now, it's usually no more than 2 injections for most patients. The first 3 injections are done in our office. We monitor the patients to make sure they're not having any adverse reactions. any side effects from what we're giving the patient, even anaphylaxis. Remember, Xolair is a monoclonal IgE. That means it has the potential also to trigger IgE, right? I touch wood when I say this. I haven't had a case ever, in all these years since Xolair has been FDA approved for other indications, of any patient having urticaria and or anaphylaxis. But technically it can. It's in their package insert, so you must monitor the patients. And after that, they can do it at home therapy with appropriate auto injectors available with epinephrine should they have reactions. So teaching and training and going over that with your patients is really important. One of the key things I think about with Xolair is that when I have a pediatric patient, that child's still growing, right? So the weight could be, 50 pounds today, and it could be 100 pounds in a couple of years. So the doses that we're going to give are probably going to be adjusted. And so there has to be very good follow-up and follow through in watching our children grow and develop and seeing how they're doing. Patients who do at-home Xolair still have to come back in. I give them a log sheet so they can monitor where they placed it on the body. And we teach and train all of that to keep track of all their data points, just like we would do in the office, so that they can email them to us or bring them in during their follow-ups.
What is the dosing, the frequency? Like how many at home? How often is the shot?
So it can be every 2 weeks, it can be every 3 weeks, or every 4 weeks. Most patients are between 2 and 4.
Okay.
Yep.
Yeah.
And then what's the difference from other, like the oral immunotherapy options or the sublingual immunotherapy?
So those are great questions. So Xolair doesn't mean, a patient on Xolair does not mean that I couldn't do oral immunotherapy.
Okay.
So it's a little different. I have this discussion with my colleagues who are in university centers, okay? When you look at the university centers, when they're doing challenges or they have food allergy centers, they're rather robust. You've got RNs in the room with the children. You've got all this support staff, right? And as part of that clinical setting. In your private allergist office, you are not going to have that matched setting. And I think that's really important to understand. For me, if a patient's on Xolair and they've been on it for about 5 months to reach a steady half-life, somewhere between 16 to 20 months on, weeks, 16 to 20 weeks on Xolair. After that, starting oral immunotherapy can be an optimal time in my private practice. It could be that we start right with OIT on some of our patients. So oral immunotherapy is starting we think of as ladders. Okay, you could have milk ladders, egg ladders, peanut ladders. So those ladders are starting at small quantities of a food that elicits anaphylaxis in a patient. And then you're kind of like microdosing all the way up until you get to full quantities in a safe way. Basically, you're developing immunogenic tolerance. So the food is no longer recognized as an allergen, but can be tolerated. In order to maintain immune tolerance, though, you need to continue having that food ingested. So typically, on day 1, a patient gets up through a certain threshold. The next day, you have the patient come back and you build on that. And then after that, the patient goes home to sustain that dose all the way through the next, until the next visit, which could be 2 weeks or 4 weeks, depending on how you've arranged it with your, patient and the family.
Okay. And then is sublingual basically the same thing? It's just dropper form or instead?
So I have not used sublingual immunotherapy for food.
Okay.
So, and I really don't, that's not the key way that most of us use it. So I really don't have that data set for you to be able to talk about.
Okay.
The traditional OIT is really taking the whole foods and microdosing and doing that. And that's well established, and that has been done very, very well. There could be some people who are also mixing it with saline and then calling that sublingual, but actual sublingual food has been purchased by some offices and tested. I am not familiar with that route, though.
Okay. And then I have actually a patient who she told me she is now doing a toothpaste. So if she uses this toothpaste every day for a year, it will desensitize her. Is that true?
It's a very interesting. I went to the Eastern Food Allergy Symposium, which was just here in Breakers. It comes every year. And there was a table for a company that's using the toothpaste food allergen with the idea of mucosal absorption. So food allergy is fascinating because we're looking at different vehicles and ways in which to desensitize the patient. And again, the concept is the same, small quantities and thinking about absorption. So again, that hasn't been one that's yet out there, in the traditional allergic world, but certainly being looked at and studied. There's also a patch that's there for peanut. So it's called the Viskin patch, which is placed on the upper back, and small quantities of peanut that's going through transdermally, right? And so that is also under studies. And so those doses would be changed over time. They're looking at various ages, 4 to 11, to see in which group of patients would it be most effective. So these are all, I think, exciting because we might have some simple ways for patients in the future to get desensitized. We don't have to worry about coming in the office and having updosing for oral, right? We don't have to worry about necessarily taking injections. It could be that we use combinations of things, though, in those patients as well, to get to an endpoint even faster.
Right.
So I think those are all studies of the future that I'm excited to look for, and then can see, okay, how can I use this in my patients? Because we all want to get to the finish line of crossing the best threshold and safety, but again, safely and surely, and knowing that that's being sustained.
So talking about future, is there anything like coming out with like a vaccine for food allergies or anything to that extreme yet that you've heard of?
Not yet.
Okay.
Not yet.
Because it's so different for everybody. I think that would be very difficult, but unless you could formulate that somehow individually.
So, you could think about component testing and think, could you start getting more peanut components for the severe allergic patients, which we know how to do. We can send to a regular lab for that. Yep. And in the future, could you target the treatments that could be that much more specific, right? I think there are a lot of people thinking along different lines, but we don't yet have the data yet. But I think that'll be exciting. We'll get more precise, right? We talk about precision medicine.
Absolutely.
And of course, that'll help us get to that.
Well, and that's the one thing I feel like you kind of do your own clinical trials in your office with your own cohort studies. I feel like you're a pioneer in this department. And
thank you.
That's why it's always neat to learn to see what's next, what's ahead.
So I've always enjoyed looking at my patients and thinking about what the different disease states there are. And I think a lot of clinicians do this. Over the years, we see certain patterns, and then we collate that data and say, okay, we've seen this pattern in this disease state or that. And then you speak to your colleagues at the academy or the college or even your Florida allergy community and say, okay, have you guys been seeing this? Should we look at this closer? And sometimes that can be quite insightful in finding solutions or even markers that we need to look at that can identify disease.
Absolutely. Well, I think you've answered all of my questions today.
I don't
know if there's anything off the top of your head that you feel like.
So I will share one thing.
Yes, please.
I think the new epinephrine devices I think would be really nice to talk about.
Oh yeah, let's do it.
We're so used to having our epi devices, having our needles, right, as auto injectors. There's a newer epinephrine device that is based on the same model as Narcan, which is just put in the nose and squeeze, an easy one-step nasal, and that's called Neffy, Neffy. So Neffy is already on the market, and it's at this time for people over 66 pounds, and of course the younger population studies will be following. And so again, comes as a 2-pack and can be prescribed by your clinician. It's at the pharmacies, and that's another easy one. It actually worked pretty well and extremely well, even in patients with a snotty, cloggy nose, which I was concerned. And the parameters that we want to see really for anaphylaxis, and Brian is an internist, you know this, we want to see the systolic blood pressure being maintained and all of those, and making sure we don't see cardiac side effects, ischemic or otherwise, was not seen. So that was really important. There is also a sublingual epi. Looks like a Listerine, strip that you just stick it underneath your tongue. That is, I just saw recently at the San Diego meetings for the Academy this past weekend. And again, their studies look very promising with really good outcomes as well. So again, not yet finished through all of the phases of a clinical trial, but again, exciting because it gives another opportunity for people not to hesitate, not to wait, not to have a fear of a needle, right? And also very portable to be able to carry.
Absolutely.
So I think, all these are another new options in management of anaphylaxis is exciting.
That's very exciting, actually.
I don't think I've heard of either one of those.
Me either.
Well, there, I gave you something new today. That's great.
Yes. Well, thank you so much for coming on. I
Yes.
would love for you to tell our audience how they can find you, if you're on social media, your website, your phone number, your office again.
Well, thank you. Thank you so much. I, unfortunately, am not on as much social media as I would like to be, but that's my new thing. I just
Okay.
hired someone
We're
who's going to
working on
teach
it.
me how to do that. I'm too old, but I'm going to learn how to do that. But I am in Plantation. I have 2 offices, Plantation, Pembroke Pines, and, people can find me through my office locations. Certainly, we have a website as well, asthmaallergycare.com, so they can go on the website and find information. And, happy to see patients who have this disease, who might have had, even for our functional patients who come in, so that they understand that this is not a food allergy and they can go to the right folks who can help them.
Yeah.
So we partner in my practice and collaborate with our other colleagues very much. And so this is something that patients suffer from. And if I can help them, I'm happy to do so. Thank you.
Thank you.
Thank you. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.